It's time for another 3-question warm-up. Let's get going. What are some of the risk factors for esophageal cancer? Well, for adenocarcinoma, which is more common in the United States, the major risk factors include GERD, so gastroesophageal reflux disease, and Barrett esophagus, smoking, obesity, and then diets high in nitrosamines. Now, for squamous cell carcinoma, which is more common worldwide, the risk factors are, again, smoking. You also need to add on there alcohol, diets high in nitrosamines again, and then pre-existing esophageal pathologies like achalasia, esophageal webs, and strictures. Next question. What is the most common salivary gland tumor? And then what is the second most common salivary gland tumor? And then what is the most common location for a salivary gland tumor? So first, what is the most common one? That's going to be the pleomorphic adenoma. And then what is the second most common salivary gland tumor? That's going to be the mucoepidermoid carcinoma. Now, that's actually the most common malignant tumor. It's just second most common overall. And then what's the most common location for a salivary gland tumor? That's going to be the parotid gland. All right, next question. Which calcium channel blockers can be used to treat both hypertension and tachyarrhythmia? You got to think about diltiazem and verapamil. All right, that's going to be it for the warm-up. Let's get to that lecture now.
Welcome back. Let's continue our discussion of epidemiology and evidence-based medicine by looking at different threats to study validity that can potentially creep into a study design. We've just been talking about measures of effect, that is, how to measure the effect of an exposure or intervention in a research study. If we find a significant difference in outcomes, we now know how to calculate relative risk, absolute risk reduction, or number needed to treat. But something that we need to think about first is if the results are true or not. So there are a number of reasons why a study may show good results that are compelling, but that just don't reflect the truth. That is, they are not valid. Let me mention 3 things here that should always be considered. These are bias, confounding, and random error. Let's talk about bias. Now, when bias is used in casual conversation, it usually implies some sort of prejudice or lack of objectivity. For instance, we talk about somebody with a biased opinion. But in epidemiology, that's not an accurate description of bias. What we're talking about here is a flaw in the way a study is conducted or produces an outcome that's different from the underlying truth. There's some kind of systematic error in some phase of a study which results in a false association between the risk factor and the outcome. Bias can occur in any part of the study design, but is frequently seen during the selection of subjects, called selection bias, or during the collection of data called information or observation bias. This systematic error or bias can make the effect of an exposure or risk factor on the outcome of interest appear stronger or weaker than it really is. It can go either way. So let's talk about different kinds of bias that we find in studies. I want you to follow along in your study guide while we go through this. Let's start with selection bias. Selection bias results when there is a systematic difference in the way the subjects are chosen that makes the study population different from the entire population that was eligible for the study. This is sometimes called sample selection bias. An example is in your study guide. The referral centers for a trial of a new anti-cancer drug have more patients with end-stage disease than early stage. So more patients with end-stage disease are referred than early-stage disease. So there will be a selection bias in the study. What we see here is that the referral pattern for the study is skewed toward end-stage disease. Therefore, study conclusions drawn from the data may not reflect the drug's effectiveness in all patients with this form of cancer. Now let's talk about a few specific forms of selection bias. There's Bergson's bias, also known as hospital patient bias. Bergson's bias results from using hospital patients rather than patients in the community as study participants. Because patients are hospitalized based on their exposure history, using hospitalized patients in a study can give skewed findings. The classic example was with DVT and birth control pills. Women with symptoms of DVT were more likely to be hospitalized if they were taking birth control pills because this was a known risk factor. So when the relationship between birth control pills and DVTs was studied using hospitalized patients, results were skewed due to the risk factor history contributing to the hospital admission in the first place. There's self-selection bias. This usually occurs because people who volunteer to take part in studies are different from those that don't. Your study guide says, in a study describing the association of a new drug with liver damage, a higher rate of liver disease was found among the patients that self-referred to the study than those who were solicited for the study through pharmacy records. If the reason that certain people self-refer to study population is also associated with the outcome of interest, then the results from the study may be biased. For instance, the people in the example may have self-referred because they were having symptoms that they thought could be due to liver disease. Another type of selection bias is the healthy worker effect. This occurs because the population of people who are actively working has lower disease and death rates than the general population. Your study guide says the harmful effect of a toxin exposure among active employees is underestimated because the control group is filled with people from the general population. So when a study population is chosen from an actively working population and then compared with the general population, the results may be biased. Now let's talk about information bias or observation bias, which is bias that occurs during the collection of data. First, recall bias. Recall bias results from a difference in recall between the two study groups. The example in your study guide says parents of autism patients having a more detailed recall of events and illnesses in their child's first 2 years of life compared with parents of healthy controls. When a child is diagnosed with autism or some other medical condition, the parents of those children often spend a lot of time trying to recall each and every event and exposure that occurred over the period of time prior to the diagnosis. When these parents are asked to recall details of their child's history, they will be able to give a very detailed, accurate description. When the parents of unaffected children are asked to provide a detailed history of the first few years of their child's life, it's very likely that they won't be able to provide the information with the same level of detail or accuracy. So this would result in recall bias. As I hope you can see from this example, recall bias has nothing to do with people intentionally misleading the investigators. It's only due to a difference in the accuracy and detail of the history. Next, lead time bias. Lead time bias results from early detection of disease. In some cases, early detection of disease is confused with increased survival. This frequently is seen with improved screening tests. What happens is that early detection of the disease increases the time that a person survives after diagnosis, even if the natural history of that disease is unchanged. The example in your study guide says while test PSA XYZ may detect prostate cancer before it's detected by a traditional PSA, early detection using PSA XYZ does not increase cancer survival compared to traditional PSA. So let's say the average survival after cancer detection by the old test was 15 years, and the new test is able to detect cancer 2 years earlier than the old test. So what you would see now is an average survival of 17 years after diagnosis. Does this mean that the new test and its associated early detection of cancer has somehow changed the natural history of the disease? Not at all. What you have here is merely an earlier diagnosis with absolutely no change in the natural history of that disease. All of the increase in survival is accounted for by additional lead time. So additional time is seen on the back end of the disease course. Now, late look bias. Late look bias is a bias that results from information being gathered too late to draw conclusions about the disease or exposure of interest in the entire intended study population. For example, sending out a survey to people diagnosed with a fatal illness 5 years after diagnosis. This study design will result in data collection primarily from those patients in the study group with low-grade disease or possibly those with fewer comorbidities. In order to capture the responses from the entire population diagnosed with the disease, it would be necessary to get that survey out to them immediately after diagnosis or as soon as the study would allow. Next, procedure bias. Procedure bias occurs when a study group when study groups within the same study aren't treated the same. The example in your study guide says the positive benefit of a new drug during a study simply may have been due to the fact that study participants were required to attend clinic monthly, where they received extra disease education and counseling compared with the controls. In order to avoid this, some investigators go to great lengths to try to get the control group in a given study to have the same amount of education, counseling, and medical care as the experimental group so that these variables don't contribute to a false association between the intervention and the desired outcome. Now, interviewer bias. This is similar to procedure bias. Interviewer bias occurs when the interviewer, who is obtaining information from the study population and the control population, treats those two groups differently, either in the questions that they're asked, the prompts that they give, or the way the information is recorded, or even in the way the answers are interpreted. Your study guide says an interviewer asks more questions about perceived symptom improvement to participants in the experimental group than in the control group. Okay, next is loss to follow-up. Loss to follow-up occurs when study participants no longer want to participate in a study and can't be contacted for follow-up. This can bias results if the dropout rate is very high, if there's an unequal dropout rate between the two study groups, or if those that drop out of the study are different from those that continue in the study. Your study guide says more people were lost to follow-up from the experimental group of a lipid treatment study than in the control group because of side effects of the experimental treatment. Next, Hawthorne effect. Hawthorne effect refers to the change in behavior from a study group that can result from the knowing that they are being observed. The example in your study guide says, when studying the effects that infection control education has on physicians, the investigator notes that both the experimental and the control groups improve their hand hygiene. So what we see is that people who have been chosen to be part of an experimental or control group of a study, here a study on infection control practices, will change their behavior, at least in the short term, just as a result of them being observed, of being studied. This example of hand hygiene is actually fairly common. So let's talk about confounding. Remember that confounding was another reason, along with bias and random error, that significant study results might not be true. Confounding occurs when the association between the exposure and the outcome is distorted due to a third variable, which is associated with both the exposure and the outcome. I think this is much easier to understand when it's explained through an example. So in your study guide, it says, a very strong association was found between asbestos minors and lung cancer. It was then discovered that the minors also smoked more cigarettes than the control population. This is, again, a popular example for confounding. So if you're looking at the association of asbestos exposure and lung cancer, you will find that there's a very strong association between the two. But what might not be apparent unless the investigator knows to ask about it is that asbestos minors are more likely to smoke than the other populations that may be chosen as controls. So when an investigator is looking at lung cancer rates in asbestos workers, they may attribute all of the increased risk of lung cancer to the asbestos exposure, when tobacco use is also playing a role. So you can see here that confounding is occurring because tobacco use is a third variable that's associated with the exposure, that's asbestos mining, as well as the outcome, lung cancer. So unless you know about this potential confounder and then control for it in the study, then you may end up with a distorted association between asbestos mining and lung cancer. Okay, so now we've talked about bias and confounding. Now, the third reason that significant study results may not be true is if the results occurred as a result of pure chance. Unlike bias and confounding, which are due to systematic errors in the study design or methods, random error can't always be avoided. Sometimes it just happens during sampling when the groups are different just because of chance. So now that we know about bias, confounding, and random error, what can we try to do to prevent them? Well, these errors at some level are inevitable. There's no perfect study out there, but there are ways that investigators can reduce these errors in their studies and thereby increase the validity of the study. You may have heard of randomized, double-blinded, controlled trials. Well, these words, randomized, double-blinded, and controlled, are all used to describe the ways that a study can be designed to reduce bias and confounding. So let's talk about these methods for a moment. Let's begin with randomized. Randomization means that the trial has randomly assigned members of the study population to either the experimental or the control group, which implies that each person in the study population had an equal chance of being chosen for either the experimental or the control arm. This random selection helps limit selection bias and also controls for confounding, since one would hope that the random assignment of study subjects results in the two groups having a similar baseline characteristics. Okay, so that's the randomized part of a randomized, double-blinded, controlled study. So let's talk about double-blinding. A double-blinded study is one in which neither the study participants nor the physicians or researchers interacting with them know which ones are part of the experimental arm and which ones are part of the control. In this way, the expectations of the participants and the researchers are less likely to affect their evaluation of the study intervention. Okay, so that was the double-blinded part of a randomized, double-blinded controlled trial. So now let's talk about the controlled aspect. A controlled trial means that there are at least two study arms, one with the experimental intervention and one with the control intervention or placebo. The control arm allows the experimental intervention to be compared with a placebo or a known established treatment in a study group that's otherwise similar to the experimental group. One rather inventive way of creating a control group is seen in a crossover study. In a crossover study, you have patients serving as their own controls. I don't think you can get better than this, really. So for one period of time, the study subject receives the experimental intervention, and for another time period, the same study subject gets the control intervention or the placebo. And this helps limit bias in the selection of experimental and control study groups and helps limit the effects of confounding. All right, so that's all I'm going to say about bias, confounding, and random error. Now let's go over the end of session quiz. So I want you to pause the video, go through those questions, and turn back on your video so we can go through the answers together. Okay, what is bias? It's a systematic error in the way a study is conducted that results in a false association between the risk factor and the outcome, or outcomes that differ from the underlying truth. What are some ways investigators can reduce bias in a study design? Well, randomization, double blinding, and using a control group. What is confounding? It's when the relationship between an exposure and an outcome is distorted, either magnified or reduced due to a third variable that's associated with both the exposure and the outcome. That's the end of our end of session quiz, and that's the end of our lecture on study validity. I'll see you next time.